I guess my other question for Colleen would be how does she handle the donor consent sort of as the donor may continue to grow?
Yeah, that is such a great question. And I think really some of the cord blood banker, the bank should be represented by this question, right? But it's a great question because I think it's a big debate in the field. Cord blood was originally sourced specifically for stem cell transplant, right? And that's what it is approved for, right? Is for stem cell transplant. But you're right? We started collecting, the first banks were developed. I mean, New York Blood Center started in, I think, 1993 or something like that. So now you have, but I will say, we know there have been publications, a more recent one from Hal Broxmeyer's group, the late Hal Broxmeyer, who is an amazing individual and really was the person who identified hematopoietic stem cells as part of the cord blood that is thrown away. But we've shown that these cells are stable for 30 plus years. But you are correct. A lot of these donors, and who is the donor is the real question. Is it the mom? I mean, because basically the mom is signing consent that this kid's cells are now put in storage. And what happens when they turn 18? So who owns that material? Now, most of the banks, with the explosion in the cell and gene therapy space, most of the banks have revised a lot of their consenting. They can go back and consent as well, but they've also revised their consent to say, hey, this material may be used for other clinical therapeutics outside of the stem cell transplant arena, and they have simple like opt-in and opt-out kind of consents. So this has not been a problem for us. I think there are other issues around how cord blood is collected and stored, and how these banks are federally supported, which we may run into issues for, right? So if a bank is has HRSA funding, can I as a developer take that HRSA funded unit, which is really meant for transplant? But the answer is yes, we're getting around all of these things. And I think everyone is starting to recognize, like what we're doing, we will make products ahead of time. I assume like you guys as well. We will have products fully qualified and sitting in a freezer waiting for a patient. So the problem is I can't tell the FDA that this unit is for this patient, right? Because it is not patient specific. And I think before we started evolving into this kind of use of therapies, everyone wanted to know who, you had to say, I want this starting material for this patient, but that's starting to also be reversed. And again, I think we like the fact that these donors do not have to be modified at all as our starting material, right? We can just isolate the stem cells and take it from there.
Yeah, I think no matter what the source is, the most important thing is the donor consent, the documentation, and the traceability. That's really what we found when we've looked around.
Yeah, and the FDA really wants that too, right? I can see there's some stuff about pooling. Do you think pooling is allowed because the cells you are? So there, sorry, and actually, Tyler, I'm not sure. I'm seeing some of the questions, but there was a question around pooling that I think I'll just address if we're talking about it. So you cannot, you have to get an exemption from the GTPs, right? In order to pool for clinical manufacturing, you have to get exemption. So we have now written 3 INDs and have gotten exemption for all 3 of those INDs, but you do have to go through that process. And as Kathryn was just saying, one of the biggest issues for us in pooling was traceability, donor traceability. And because we pool, we can't rely solely on all of the donor eligibility. So we start with a cord blood donor that is fully eligible, meaning all of the infectious disease markers, the consent, all of that stuff that we've been talking about is already there. But because we're pooling and because we have ultimate scalability, because we pool, we are doing manufacturing runs that will hit, say, hopefully, hundreds to thousands of patients with each run. And that's why I think the FDA is so concerned about traceability. It's not a one, starting material for one person. It's so many. So we are required to re-look at a lot of the IDMs, the infectious disease markers at the end of manufacturing. So I hope that addressed that question.